Physical signs, the urine. Pus is practically constant in the urine in sufficient quantity to cloud it. I have failed to find it only twice. Once in a case of intermittent profuse hematuria due to a small papillary ulceration, the other time in a case of closed pyelonephrosis that was delivering no urine whatever. Albumin is equally constant, usually a trace. The presence of any appreciable percentage of albumin usually means grave toxic nephritis of the opposite kidney and is accompanied by casts. In the absence of this, toxic nephritis casts are not likely to be found. Blood is commonly present in microscopic quantity, and fully half the cases give a history of gross hematuria. A striking feature of the urine is that it is likely to be sterile on ordinary culture media if drawn from the bladder, even though definitely purulent. Such a sterile, purulent urine is likely to be caused only by the tubercle bacillus or the gonococcus. Bacillus coli or other infection of the opposite kidney is, however, present in a large minority of cases. The urine is acid unless rendered alkaline by mixed infection. Tuberculous lesions elsewhere in the body. At the time of the first examination, the bladder will be found infected in about 90% of cases. The opposite kidney in from 10 to 20%. Slight prostatic infection doubtless occurs early in many men, but is usually overlooked. The infection reaches the epididymis in only a small percentage of cases. Radiographic evidence of tuberculosis in the lungs is usually obtainable through the clinical history, though the clinical history is often silent on this point. Bone and gland tuberculosis are rare complications. It has been noted that a singularly large proportion of patients with genitourinary tuberculosis die of tuberculous meningitis.